Please send the chat.
Oh, I do see two chats. Before we go, let me just check. Oh, Carrie's just saying that she can hear things.
Yeah, I'll be monitoring the chat.
Okay, very good. Excellent. All right, well, I turn it over to Renette Jonas.
Okay, so as you guys remember, last month we talked a little bit about the different seizure types and how we can identify them, and maybe we touched a little bit on different epilepsy syndromes. Today we'll try something different, which is quite hard. So the first question when we have a child that comes with some kind of a paroxysmal spell is it a seizure or not? Because we know that there is a lot of other spells that might look like seizures. Okay. That's not the first one. Okay, so I'm going to show you a video on an infant baby who has some jerkiness, and if you guys would be live here with me, I would ask you if you think it's a seizure or not. Maybe I'll give you like a second or two to write us to in a chat. Do you think that this little infant baby, who is otherwise doesn't have any risk factors, had normal pregnancy and delivery, is doing otherwise fine, but every time that he falls asleep, he has this jerkiness that we see there's fine twitching, sometimes just one extremity, sometimes all four. It's kind of a little bit irregular and erratic. It's not very rhythmic. And what can you do to try and identify whether this is a seizure or is it something different? I'm going to wait. You guys can write now if you think it's a seizure or not. 3, 2, 1. Okay, so I don't get any response. So I have to say that when I do it live, most residents will raise their hands up and say they think it might be a seizure, but this is actually not a seizure. This is a benign sleep myoclonus of infancy, which we see quite a lot, and we get many times a consult actually for this kind of babies. And one of intervention that you guys can just tell the parents to do is to wake the baby up. So even if the baby is in deep sleep and we try to wake him up, this will disappear. So it never happens in wakefulness. Sometimes it can be very prolonged. It can go on for hours and hours and hours. So it might even look like a status epilepticus, but really the baby doesn't have any vital sign changes. The baby doesn't have any color changes and doesn't seem to have any breathing difficulties. So all of this may help us to decide that it's actually not epileptic. Sometimes we have to admit these patients and have an EEG with a video to be able to make the diagnosis. So let's look a little bit on a table that would kind of summarize the few more common seizure mimickers according to age of onset in the infancy, toddler, childhood, or adolescence. So jitterness or tremor is very common. We see it many times either in full-term or even preterm babies. We see it a lot in babies that are exposed to NAS, but not only. We can see it in children who are a little bit in infants who are a little bit hypoglycemic. And I would say that this is probably also quite a common reason for consult in the newborn period. One of the things that you can do is that usually you can stop it. If you touch the patient, you put your hand on the baby, and you try to flex and extend, let's say, the arms, usually you would be able to stop it. Benign sleep myoclonus we just saw. Shudder attack, I have to say I also have seen quite frequently in this last few months. This happens in young children, few months old, and can go up to 2 to 3 years. Usually it will go away by that age. And the baby has a shiver-like spell. And if I would be able to show you, I would kind of perform it, but I don't have it. It's usually...
You can do it.
Oh, they see?
Yeah, we can see
okay,
it.
all right. So usually it would look something like kind of a very fast shudder of the upper body. Sometimes the hands may be a little bit also involved. It happens most frequently, they actually say, when you're sitting, and many times during feeds. It's a benign phenomena. There is many times family history of essential tremor in any family member. Again, this is a benign disorder that we do not need to do anything except for reassuring the parents. Sometimes, again, it's very frequent. Parents are very concerned, and we do bring this patient to do a video with an EEG. Again, very helpful if the parents can actually take a video of the events and show it to us. Sun differ or reflux, again, quite common, where the baby has discomfort because of reflux and gets into almost like an epistotonic tone. Again, you can, with a history, get it. It is related usually to after feedings. Sometimes it's quite severe, can have some color change, can have some gurgling noises with it, so might mimic a seizure. What we used to call ALTI, apparent life-threatening event, again, can be due to seizures, can be due to cardiac issues, but most of the time we actually do not find a reason for this events. And spasms mutans is again a movement disorder like spell, where babies might have some torticollis that might be either fixed or sometimes intermittent, might have some abnormal eye movement that go along with it. And again, it's a disorder that is not epileptic. In toddler, most frequently we will see breath-holding spells, and I'm going to talk a little bit more about it. We see stereotypies, which are repetitive movements, usually involving the arms. The child usually will kind of flip and make different kind of movements. We think about it that it's seen only in children with autism or with children with developmental delay, but this is not true. This is also seen in normally or typically developed children. It's usually more common when the child is either very happy or excited, or when the child is upset. Tic disorder, either motor tics or vocal tics, that can be simple or can be complex, or Tourette syndrome is again a frequent consult for pediatric neurology regarding questions of seizures, especially when there's eye blinking involved in that. Parasomnias. There is a wide range of disorders that can happen at night, and I might talk a little bit about it if we have more time at the end. If not, it's going to be a topic by itself. Self-soothing behavior, like rocking, like different kind of movements, or even what we call infantile masturbation, where we have a child that might, more commonly girls, they resume this almost like tonic posturing, and then some rocking of their body. There's usually color change. They might become diaphoretic. So that is kind of many times concerning and might look like seizures. And then we have the movement disorders, paroxysmal dyskinesias, where you might have either dystonia or you might have different falls due to channelopathies. In adolescent, the most common would be migraine, and we're talking more about the complicated migraine, where there would be some other phenomena that goes along with the headache, like weakness on one side, or like altered mental status, or some visual changes. Syncope or POTS, which I'm going to talk a little bit more about it later, is also, I would say, quite common consult for pediatric neurology to differentiate between that and a seizure. Again, different movement disorders like we see in the younger population. Cataplexy, which is a part of narcolepsy, which is again movement sleep disorder, where you totally lose tone and fall. It might look like an atonic seizure. Again, taking a good history and seeing that it usually would happen when the adolescent is actually laughing or has emotions. That's the most common time when this cataplexy would happen. And then we have what we used to call psychogenic seizures or non-epileptic seizures that are not always easy to differentiate. Sorry. Why don't I go to see my screen?
You can move this to the side. So there's one chat.
All right. So how do we differentiate between seizures and the look-alike? So really, most of the time it's a good history. It's true that not always the history is the only thing that is helpful, but many times it gives us 90% of the diagnosis. So seizures are usually paroxysmal, so they're not all the time there, but true that a lot of other things that we were talking about before, there's also paroxysmal, they're intermittent. They're usually stereotypical, so they look quite alike. So we don't like to have somebody who has seizures that look differently in every time of presentation. Compared to tics, for instance, that kind of tend to change. They might be first in the eyes, and then they go to your face, and then you have some shoulder shrugs and so on. They're usually brief, last seconds to minutes, so it's not hours. They usually cannot be interrupted. And one of the more common presentation would be a child that comes and is staring, and the parent says, he does not respond. I called your name, I wave in front of them, they do not respond. So children may be daydreaming and they're in their own world, so you really need to touch the child. Hey, are you there with me? Rather than just kind of waving and calling. With many of the seizures, not with all, we have a post-ictal period. We talked about it last time, where the child is confused or very lethargic. Many times there is no memory for the events, especially with the seizures with loss of awareness. True that the simple partial seizures where they would have only maybe some jerking, they are going to remember that. But a lot of the other spells, the child might have some memory for the event. Then there's different triggers. So if somebody had just their blood drawn or was very upset and then fainted, so there is kind of a flavor that it was provoked. And the other thing is hallucination. So we get many times referral for temporal lobe epilepsy. So somebody who is a psychotic or just has some kind of hallucination, and the question is, might it be seizures? Just one point is that usually hallucinations in epilepsy or seizures are not threatening. So it's not that they hear voices that they tell you to hurt somebody or to kill somebody. It's usually more forms or colors. So let's look at this little baby. And again, otherwise quite healthy. He's crying. I don't think that you guys can hear it. Mom is trying to console him, and then he goes into this epistotonic increased tone for a few seconds, and then he's back to himself, maybe a little bit kind of tired. Again, he's crying. Mom tries to console him. And soon he will have another spell. Now it can cluster, and I have to say, when you look at it, you might say, might that be actually what we call epileptic spasm, but an extensor spasm, where you go backwards rather than forwards. And of course, we would not want to miss infantile spasm. A good history might be helpful to see that it usually happens after feed, so the child is otherwise doing fine. And sometimes if it's very severe, we might need to videotape this child together with an EEG. Here's another one. I want to talk a little bit about breath holding spells because they can actually be quite frightening. They're very common. About 5% of the healthy children will have it. It can start anytime between 6 months and go on to 6 years, with a peak age usually around 1 to 2 years of age. It can be either cyanotic, where the child becomes really blue, or pallid, where the child is pale. Usually the cyanotic one are triggered by crying. So the child is upset, they don't get their way, they start crying, 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 crying. And then during actually expiration, they stop breathing. They become cyanotic, they become actually anoxic, and they may end up with an anoxic seizure due to decreased oxygen to the brain. And it may look very much like a seizure at the end. The pallid breath holding spells are usually more due to either a fall or some kind of, the child got anxious or afraid from something, and they might get into this same kind of a spell. There's usually some family history, but doesn't have to be. And it is very important to make that right diagnosis and to reassure the parents, because it tends to repeat itself. It can happen many, many times a day. It can happen once in a while. It's important to try and remove the triggers, but avoid reinforcement, so not to give the child any positive feedbacks. Try to see if we have a trigger that we know that that will get the child into that, to try and remove it. It may be associated with low iron storage, and therefore we usually do check transferring on these children. And if it's lower than 50, we supplement it with elemental iron, and I see that there is some typo there. It's supposed to be 6 milligram per kilogram daily of elemental iron. So a little bit about fainting spell. I want to talk a little bit about the difference between an adolescent that comes in that says, I woke up in the morning, I went to the bathroom, and then I don't remember anymore what happens. The family found him down, hit his head on the sink, and so some tonic posturing and shaking of the extremities looked like a seizure. This adolescent doesn't remember exactly what happened before, but does endorse that from time to time might have some postural symptoms, that when they get up too fast from laying into a sitting or standing position, they feel a little bit dizzy, they might have some tunnel vision. So really history would help you a lot to make this differentiation between the two. So with the syncope, like I said, there is quite a lot of triggers. It's your position, so it happens only when you're standing rather than when you're laying down or sleeping. If you're very emotional, you had a blood drawn and you're quite concerned or upset or afraid, or Valsalva maneuver. While with seizures, it's quite rare. It's much more common to feel nauseated and diaphoretic with a syncopal event than with a seizure. Also, it can happen sometimes with seizures. On the other hand, it's much more common to have an aura or unilateral shaking with a seizure compared to syncope. It's more common to have automatism, like lip smacking or finger flicking with a seizure compared to a syncope. On the other hand, tongue bite can actually happen in both of them. However, in syncope, if it happens, it's usually going to be quite rare and maybe more on the tip of the tongue. On the other hand, seizure, it's more common to have it on the side, so it's lateral. Hypersalivation and frothing, again, more in seizures. Color change usually would be more pale in a syncopal event, grayish pale compared to cyanotic perioral cyanosis with a seizure. However, some temporal lobe seizures can actually give this autonomic changes that might look like a pallor. The loss of consciousness is usually more prolonged in seizures than in a syncopal event, and the convulsion is a little bit different. So in syncope, The convulsion, the major phase is tonic, actually, posturing of arms and leg, and then you might have few clonic jerks, and it's usually less than 30 seconds. On the other hand, in seizure, the tonic phase is much shorter, and then you go into a much more prolonged clonic phase. And like I said, it's usually longer than 30 seconds. Confusion or disorientation can be seen in both, but it's much more common in seizure, and it's usually more prolonged compared to the confusion that or lethargy that you might see after syncope. It is quite important to understand that you can have a seizure due to anoxia or loss of oxygen to your brain. However, the treatment would be very different. We cannot treat them with anti-epileptic drugs. That's not going to help. So it's really important to make this differentiation. What is not so helpful? So we sometimes think that incontinence, either urine or fecal, is seen only in epileptic seizures, but that's not true. It's actually reported also in syncope. Prolactin level is usually elevated in generalized tonic-clonic seizures, so it can be quite helpful with generalized tonic-clonic seizures, but it's not always elevated in other seizures like the complex partial seizures. Dizziness can be seen in both. Fear can be seen in both. Injury, other than lateral tongue bite, can be actually seen in both. Rolling eye movement up or to the side can be also seen in a syncope, and the brief automatism, again, is not very helpful. I want to talk to you guys a little bit about POTS, or postural orthostatic tachycardia syndrome, because I'm not sure how everybody is familiar with this syndrome. And I have to say that probably in the last 3 months, I had at least 7 adolescents that presented with what sounded like vasovagal syncope, or what sounded sometimes even like a seizure, or some of them even like a panic attack. And they actually had this condition. So POTS is a dysautonomia where you have orthostatic intolerance and increased heart rate. And one of the difference compared to what we think about the postural hypotension is that usually in this condition, the blood pressure actually remains fine, but the heart rate goes up. It's much more common in females between the ages of 15 to 50 years, and that's, I would say, about is the population that I see, kind of around puberty and late adolescent. And the diagnosis is actually quite simple. You can send them for a TIL test, but I just get the diagnosis in clinic, where you need to have an increase of 30 beats per minute. In children, you would say 40 beats per minute or more. Or you have to have, at any time, a heart rate above 120 within the first 10 minutes of standing. And that's in the absence of decrease in blood pressure. So what I do, I have the patient come in, they lay down for about 5 minutes, I check their heart rate and blood pressure, and then I have them stand fast, and I check heart rate and blood pressure again within 30 seconds, 1 minute, 2 minutes, 3 minutes, 5 minutes, and 10 minutes. And if during any of that time their heart rate goes above 120, or there is a change of more than 30 beats per minute, that's already what you need for the diagnosis if you have the right symptoms and you don't have other disorders. Of course, they cannot have a cardiac condition, they cannot have a neuropathy or so on. Otherwise, they should have a normal neurological and a cardiac examination. The symptoms are quite non-specific, but can really look like, I would say most of the ones that I see, a little bit like kind of generalized weakness or fatigue, or panic attacks. So they have fatigue, they have headache, they have lightheadedness, they have palpitation, exercise intolerance, they're nauseated, they have diminished concentration, they're quite tremulous, they can faint, they feel sometimes cold or pain in their extremities, they might have chest pain, and they might have shortness of breath. And a lot of them are actually also a little bit have anxious personality, so it might be a little bit confusing to make the right diagnosis. The treatment is to increase fluid and salt intake, so very similar to what we see in orthostatic hypotension. compressive socks, and I have a nice website that I give my patient where they can get this fashion compressive socks. The best is if it really goes very high into your thigh, but nobody actually would use it. So it's enough if it's up to the knees. And then exercise for conditioning. So a lot of these isometric exercises which might help them. And then there's pharmacological treatment that goes from flurinef that we give sometimes for orthostatic hypotension to mestinon that is actually used in myasthenia gravis to some of the SSRIs. So this is a condition to remember, because I'm sure that you guys are going to see patients with this condition. Let's look at the video of this little girl. And unfortunately, I don't know why today we don't hear the, oh, I know, we don't hear so much the video, but she has eye blinking. But during this time, she's totally able to talk, she's able to respond, she has eye rolling up, and she has it multiple times a day. This is quite typical for simple motor tics that, okay, sorry, that involve the eyes. Staring spell. So how many times do you guys see kids in your clinic that present with staring spells? Parents can't exactly describe how many a day, many times seen in school. It's not clear if the child is just daydreaming. Is it more than that? The child, you wave in front of their face, they don't respond. Can be seconds, can be minutes. So it's really kind of a large differential diagnosis from daydreaming to just being oppositional, to being depressed, to have ADD and kind of lose focus and kind of be in your own world, to some learning or intellectual problems, to hearing impairment, and to seizures. And seizures that present with staring spell can either be absence seizures or can be complex partial seizures that are usually either from the temporal or the frontal lobes. So if I see a patient that comes with multiple staring spells, and I had just last week a patient that mom said has some staring spells and eye blinking, but they were referred also to ophthalmology. Ophthalmologist found something on their exam, and mom said, I'm sure it's nothing. It's probably just related to this ophthalmological problem. But we had an appointment, so we anyway came. So what can we do in clinic? We can hyperventilate them for 3 minutes, and I did hyperventilate this child, and he had clear multiple absences during hyperventilation. So a little bit about our staring seizures. So like I said, it can be either absence, and absence is a generalized seizure, where if we look at an EEG, we would see that both sides of the brain are firing together. Or it can be a complex partial seizure where the seizure is starting in one lobe. Like I said, it's usually either the temporal or the frontal lobe that can give us such presentation. In absence seizures, we have usually multiple a day, especially in childhood absence epilepsy. It can be hundreds a day. On the other hand, complex partial seizures are much more infrequent. They happen here and there. Absence seizures are usually quite brief, 5 to 10 seconds, compared to complex partial seizures that are much longer. Most children with absence seizures who have childhood absence epilepsy have normal development compared to complex partial seizure that can be either normal or delayed. With complex partial seizure, very common to have automatism, licking, smacking, some hand movement. On the other hand, absence seizure, it's less common, but we still can see it. For instance, the child that I just saw last week who had this absence had always licking of his kind of lips after the absence. With absence seizure, there's an immediate recovery. It's a very abrupt onset, abrupt offset. You're back to yourself, compared to complex partial seizure that has some kind of an evolution, and then many times post-ictal state where you're confused or lethargic. And absence seizure is easy to make the diagnosis in clinic while you hyperventilate the patient. On the other hand, complex partial seizure will not have that effect. And of course, an EEG would be very helpful. I think I have a few seconds, and I'm going to talk a little bit about non-epileptic seizures that we see quite a lot. Some of their characteristic is that they have a very gradual onset, and there is some kind of waxing and waning to their quality. So it's faster and then slower and then faster and slower. And the motor activity is quite arrhythmic. Most of the time with seizures, we would like to see open eyes. So most seizures, not all, but most seizures, even if they're nocturnal, even if they happen during sleep, the patient opens their eyes during the seizure. While in non-epileptic seizures, the eyelids are closed usually. They're usually very prolonged, can go on for 15 to 20 minutes. There's some movements that are less typical for seizure, like trashing and bicycling, side-to-side rolling or pelvic thrusting. There can be a tongue bite with it, but it's more typical to be in the tip of the tongue rather than on the side. They're usually, when they're post-ictal, it's more kind of hysterical post-ictal. They're crying, they're shouting. There is a suggestibility. We can tell them we would like you to have one, and we get a seizure. It's interesting that they may not respond to painful stimulant, and there's clear reports of non-epileptic seizures that the patient gets intubated and does not resist. And then there is many times a psychiatric comorbidity. And I'm going to show you an example. So this is one of the patients that we had in. And if you see on the right side, we actually see that she's awake. She has a normal, nice background. We see a nice posterior rhythm, both on the right and on the left side. There's some movement artifacts. She starts moving her head from side to side. Dad is seeing that something is not right. He's talking to her. He's trying to get her attention. She doesn't respond. Again, we see that the head movements are a little bit faster, then a little bit slower, so kind of a little bit of waxing and waning. Again, the EEG continues to look very nice. There is no slowing. There is no spike in wave activity. And then now she starts with real kind of whole body shaking. Again, a little bit arrhythmic. She has a lot of rhythmic activity now on the EEG, but this is all movement artifacts, exactly in the same frequency of her shaking. The nurse comes, the nurse tried to stop it, and it goes on and goes on. I don't have all of it, but it went on for about 15 minutes. So this is quite typical for a non-epileptic seizure. And I think that, like I said before, we are going to leave all the nocturnal events for a different talk, because it's actually quite interesting. And again, with a history, you will be able to differentiate between a night terror, nightmare, confusional arousal, or some nocturnal seizures. And thank you for today. I think that we're good to go.
Great, everybody.
Thanks, Renat. It's Julie here. I was hoping that folks could just type into the chat feature to let me know that you are here. I know Carrie is here and Christoph is here, but anybody else who I didn't mention, if you could just type your name in the chat function, that would be really helpful. If you're calling in by phone and you can't type into the chat, could you just shoot me a quick email and let me know that you were on the call today? julie.rollins@bmc.org. And I think Lori had something to say. I just also wanted to mention our next meeting is April 24th at 12 noon. And I apologize for the technical glitch that we had today, and we'll work to get that resolved in time for our next meeting on April 24th.
Right. I will be sending out a link to this recorded session. And with that, I'm going to send a little survey so that I can get people's input. I'm thinking that at the next visit, we will not do it webinar style with the recording, because I'd really like to be able to chat with each of you in a group format when we do